Good evening, ladies and gentlemen. I'm just giving a minute or so. There's still plenty of people joining. Okay, right. I think we can get going. Good evening, ladies and gentlemen. I'm Chris Forster. I will be the host for this CPD event. This webinar series is sponsored by Sanofi, and we are thankful to them, and we just like to assure you that they have no influence over the topics and the content that is presented in this webinar series. So tonight we have a speaker that I actually think do not really need an introduction in South Africa anymore. Professor Chris Hendriksz is Chief Medical Officer, Decentra Health Chief Community Impact Officer at a rare course. Decentra Health brings together successful entrepreneurs, technical experts, and industry leaders to drive the development of life-saving therapies through innovative data solutions, leveraging AI technologies. Its proprietary real-time data sharing technology enables secure collaboration across registries, health platforms, and patients without moving data, while remaining fully compliant with global data protection regulations. Professor Chris Hendriksz is a South African-trained medical doctor who earned his degree and a master's in sports medicine from the University of Pretoria. After his child was diagnosed with a rare disease, he relocated to the UK, where he became leading expert in inborn errors of metabolism. He trained at the renowned Willink unit in Manchester and earned MRCP and FRCP-CH credentials. Over 22 years in the UK's NHS, Dr. Hendriksz led rare disease centres in Birmingham Children's Hospital and Salford Royal NHS Foundation Trust, each serving over 1,500 patients. He currently holds professorships at Human Metabolomics at Northwest University and in Pediatrics at the University of Pretoria. Until March 2024, he served as Global Clinical Development Lead for Rare Diseases at Nestlé Health Science. Now he is Chief Community Impact Officer at a rare course, a UK-based non-profit educating clinicians in over 50 countries. He also consults for FYMCA Medical Ltd, advising patient groups, regulators, and payers. Professor Hendriksz has authored over 250 publications, primarily focused on rare diseases, including clinical trials, quality of life studies, guidelines, and book chapters. It's always very insightful to listen to Professor Hendriksz. So, Chris, thank you very much for taking the time to present, and I look forward to your presentation.
Good, thank you, and I hope you can hear me all. And let me first see if we can get the screen going. And can you see the full screen?
Yes, we can.
Good. Okay, good evening, everyone. So I've been given this fairly large topic, and I prefer to talk about things I know about rather than I don't, and you'll see what I mean with that as I go through. So Chris has already given you the introduction, and this is just to make sure that my disclosures are up front. And really what I wanted to say to you is that I'm speaking mostly from my experience, and most of it will be referenced. So please feel free to go to the publications. So I'll start off with something that everybody should know very well, and that is that firstly, when you look at cardiac disease or heart disease, people talk firstly about congenital heart disease. But it's really important to remember that this is multifactorial. So this involves multiple, including genetic conditions, but there will be syndromic, Fallow's tetralogy, and things like that, which are syndromics. There are specific genetic conditions, but there's also infective. So it's a wide spectrum of disease. When we talk about genetic heart disease, these are cardiac conditions which has got a known genetic defect, and they're primarily cardiac, with not anything else. And then when you look at inborn errors of metabolism, these all have genetic defects, but we may not have found all the genes. So a little bit of the differences comes in there. And for those of you who've forgotten what the heart looks like, just to quickly remind you, on the left is the bundles of the electrophysiology, and on the right is the simple way of looking at the heart. But that's not what we're talking about today. So how do we classify cardiac disease? Now, I'm going to have this kind of schizophrenic presentation today, talking about the things I know and ignoring the things I know very little about. But when you look at the cardiac disease, the first thing is you can look at diseases affecting the muscle, what we call cardiomyopathy. And then the MYH7 defects are most probably the commonest reported in the world at the moment, specific genetic defect. On my end of the spectrum, when we talk about cardiomyopathy, the first thing that people think about is Pompe, but I'm going to try and convince you at the end of the lecture that actually it's much wider than that. Then the next thing is we start looking at things that affects the structural elements. And usually we mostly talk about valve disease. And again, you've got the two options here. The one is things like infective rheumatic fever, very common in sub-Saharan Africa, compared to the MPS disorders, which are much more genetic. And then, of course, lastly, you've got the electrophysiological ones. And these are mostly rhythm disorders. And there are things which we all learn in med school, like Wolff-Parkinson-White, WPW, compared as a genetic condition compared to Fabry disease, which is another inborn error of metabolism. So you see this kind of different ways of looking at the same specific areas of the cardiac system. So what is the incidence? So the overall incidence of pediatric cardiomyopathy is about 4.8 per 100,000 or 1.3 per 100,000 less than 10. Now, if you do your sums quickly, you will then see by default, cardiac myopathy is the commonest between the ages of about 10 and 18. So less common in the younger age groups. If you then specifically look at inborn errors of metabolism, they account for about 5% of all cases of cardiomyopathy, and of course for about 15% of the non-idiopathic cases, because we all know there's quite a large group of idiopathic cardiomyopathy cases, but as the whole genome sequencing and things is getting better, more and more of these are being cut out, and they are becoming rather diagnoses rather than idiopathic. And then really important for us looking after patients with inborn errors of metabolism is to be aware of the risks and continue to look and keep a very close eye on their cardiac presentations. So that's just a kind of a incidence overview for you to get it started. So I thought this would be really interesting for you to see. So this is a review that came out very, very recently, and it talks about genetic insights into cardiac hypertrophy, pathogenesis, diagnosis, and therapeutic implications. And I was absolutely fascinated to see this, because when you look at this list, you can see there's a lot of the common disorders which we talk about, which are the genetic ones. But when they go to the kind of syndromic ones, which is to the left, I was fascinated to see that GLA is there. So for those of you who don't know, GLA is Fabry disease. And actually, we don't see cardiomyopathy in the true sense in that. And similarly, we do see it in LAMP2, but not in Fabry. So the main message I want to be is not to be hypercritical, but just say a little bit, be really, really careful. Most of the reviews does not include the inborn errors of metabolism or touches on them briefly. I mean, you can drop down here and you see mitochondria, MTTI. What about the more common disorders of mitochondrial disease? So you can see why be really careful at reviews, that because they don't mention them. And then the other thing is, because of that, when people are building cardiomyopathy panels, they frequently do not include the IEM causes, which means when you see a cardiomyopathy, you say, oh, everything's been excluded, including the metabolic causes. You see it, the images like these, that actually that is very untrue. So it's just important to keep that in mind. So please, please, please don't trust the panel if you believe the patient has got an inborn error of metabolism. Next, what are the differences between the different groups? Well, firstly, in IEMs, we usually say, or inborn errors of metabolism, you're going to hear me talk about IEM, is usually multi-organ disease. So you have cardiac plus something else. It's very unusual to have only cardiac disease. So look always for the plus. And once you've got cardiac plus, you really need to be worried. Genetic causes usually cardiac only. The other thing as well is, as the disease progresses, you find out that actually the disease progresses over multiple domains as well. It doesn't affect one system. It's usually cardiac plus liver, cardiac plus muscle. It's combinations. Whereas when you look at genetic cardiac conditions, the pure cardiomyopathies, they tend to be cardiac only, and all the progression you see is linked basically to the cardiac disease and is secondary to that, but there are no other primary causes. And then really the other thing as well is that for inborn errors metabolism, we've got a really heterogeneous age distribution. And people talk about different types of it, and I'll tell you, I love to talk about classical and non-classical phenotypes because there is so much variability, and I'm going to talk about one of those today. But I find it really confusing when people talk about different age groups. And the other thing that I found really confusing is that some people also talk about primary disease and attenuated disease. Now, I know it's a common term, and in many publications, I absolutely hate that term, purely because attenuated, if you look at the term, means not really important. So when you talk about an attenuated vaccine, it is something that looks like a vaccine, and it's got all the actions, but it doesn't have real disease effects. And many times when funders are looking at funding patients and you talk about attenuated disease, they've got the same perception. This is a patient that looks like they've got disease, but they're not really impacted by it, which is why I like to use the different classification. And I'll show you, here's my example. And I've taken this off Sanofi's website because I think it's really important just to put it out there because it's there for educational purposes. But you see that you've got this infantile versus late onset Pompe. So infantile, of course, is babies. Late is older. So what happens in the middle? And we do know there's a middle because there's also a juvenile onset of Pompe disease, which is a mixture between the two. And this is the first lesson that really inborn errors of metabolism is a spectrum. It's never cut off in little blocks. This is early onset, this is late onset. It's usually a spectrum. And that's why I love talking about classical and non-classical. So when I talk about classical Pompe, I talk about Pompe disease with cardiac involvement. When I talk about non-classical, I talk about Pompe disease without cardiac involvement, because you can diagnose a Pompe patient from newborn screening and they will not have cardiac disease because they may have the adult onset phenotype, which is why I do like using the terms classic and non-classic, but I won't get that tied up too much, but just that when I talk through it, you'll know why I get there. So, infantile Pompe, what are the clues? Well, you have to take a previous history. Now, if this is a second pregnancy, you may have had a previous infantile death or a young age death. So it's really important to get that. Or a family history. We tend to find quite a lot of the patients has got a family history. Usually here, oh yes, we've had somebody else who died in the family. There was a sibling or an early death in the family somewhere along the line. And this is particularly important when you've got consanguineous families where you can trace the history out further. But things that are starting to become more and more prominent, and I'll tell you why it's important, is that people are now looking backwards and they say, but actually, now that I've had a normal baby, my previous baby with Pompe had really reduced fetal movements. It really was not moving as much. And there was mild polyhydramnios, not large, mild. And then, of course, when you do cardiac imaging in late pregnancy, you actually see the disease developing already. So here is a case report, which I showed you on the right-hand side from the group in China that's taken. So at the bottom, you will see the ultrasound. So that's an intrauterine ultrasound, which was taken at about 39 weeks. And that actually showed already significant hypertrophy of the cardiac muscle. So it does show you that although we say we do an anomaly scan at 20 weeks, it's the standard procedure across the world, things like Pompe, you will actually miss. So be careful when you say to people they're entirely normal at 20, they may develop a little bit later. And then at the top, you will see the image of the baby. Shortly after the baby was born, they actually took the chest x-ray, and you can see this is a child with a massive heart. I don't need to tell anybody, you can see that. And that's fairly classical of Pompe disease. And then, of course, once baby is born, they tend to be hypertonic. So they've got poor feeding, not always, may take a while, but they're generally not the best of breastfeeders. And then, of course, most of the time people think, oh, there's a little bit of infection, take a chest x-ray. Oh, this is just a little bit fluid on the lungs, the heart size. Oh, I'm not really good at heart sizes and it looks okay to me. So let's send him out. So just keep that in mind when you see x-rays in young babies. Then But what is the early management then for these patients with Pompe disease? Well, firstly, like the old adage is, you only find what you look for. So unless you're suspecting a condition, you're never going to find it. And then if you want to do prenatal testing, you can actually do prenatal chorionis villus sample testing about 10 to 13 weeks, or amniocentesis at about 15 to 20 weeks. Amniocentesis is less reliable. Chorionis villus sampling is the most reliable. There's multiple quality control issues, but actually that is something which is really important. So if it's a known patient, a second pregnancy, this is something that you can do, and you can actually make the diagnosis really early. And I'll quickly later talk about why this is important. But let's say baby's already born. What do you do next? Well, if you watch Chris Foster's lecture last week, there's a really nice online tool, and basically remember 6-plex test. That 6-plex test actually has Pompe in, and it's really important to not forget about that. So it's an easy test to do on a dried blood spot card and to be sent off. The next important thing is when you've got a patient confirmed with Pompe disease, it's really important to get a confirmation of both the gene, because that usually informs what is the CRUM status. And I'm going to tell you a little bit more about CRUM status just now. And then because when patients are CRUM negative, it means they've got no natural enzyme. They've got very high risk of immune response to your enzyme replacement therapy. And in most countries of the world, when you're CRUM negative, we now say you need to do immune modulation as soon as possible and starting it. And we also know the outcomes are much, much poorer when you are CRUM negative than when you are CRUM positive. And I'll show you some data on that. Now, CRUM status can be determined by mutation. If it's a well-known mutation, which is CRUM negative, it's relatively easy. Sometimes the genetic type of mutation can give you an idea. And then, of course, you can do either Western blot in blood or fibroblast. The challenge is with fibroblast, as you will know, it takes about 4 to 6 weeks to grow a fibroblast. Then you need to start testing. So you get to 8 to 10 weeks before you're there, unless you are off the mark immediately. So it's really important. I favor the way of looking for mutation first and seeing if it's a known mutation. If it's not, then move on to whatever is available. Then much more and exciting at the moment is, and I'm pretty sure people have heard about it, and that is what's called NIPT. So basically, this is the little image on the right-hand side. So from about 8 weeks of pregnancy, there are significant amounts of fetal cells already in the maternal circulation. So you can harvest them, and you can take these fetal DNA and you can put whole genome exome on it, or if you're looking for a specific mutation, you can test it. And there are multiple studies running across the world now looking at this NIPT. Now, there was a recently scoping review of NIPT in South Africa. The reference is there for you, talking about why it will be very different to do it at the moment in South Africa. But let's not forget, what is very difficult now may not be in 5 years' time. And it will change very quickly, because I think once people see the benefits of this, it will rapidly expand. And at the moment, I know NIPT is available to many people as a private service. So I know multiple people in our country where NIPT is available for high-risk families, but those who are lower risk actually pays for their NIPT to try and see what it is. But I'm not going to talk about the risks and things of whole genome sequencing and everything related to it. Just remember, it can be done. And again, you will see a little bit why it's important that you can actually diagnose children before they are born. So this is a really important paper from not so long ago. It's all the updates and things. When you look at it, this is what happens. So if you look at this is a Kaplan-Meier plot. At the top, you see the Pompe infants, which has got CRUM positive disease. So these are your patients which has got some enzyme activity. And when you look at the ones with a kind of dotted line, that's all your CRUM negatives. And when you come down, you will see when you've got a CRUM negative patient, by about 24 months, they are all ventilator dependent. So that is why it's so important to look for the CRUM status. Whereas when you look at the CRUM positives, you will actually see that about 60% of your patients is not ventilator dependent even by the age of 7. So the difference between the two groups is stark. And that's why there's been so much emphasis on trying to get the CRUM status and how to improve the outcomes. And the biggest outcome change has been to do what's called immune modulation upfront and very early. The challenge being in many LMICs, the drugs for immune modulation is not available. So it's a no-go. And it puts you into the ethical situation. Do you make an informed decision not to treat Gram-negative patients? And that's a social issue which people need to decide about for themselves. So looking at what are the different treatment strategies then? Well, firstly, we don't need to always say run to the enzyme. Start off by genetic counseling. Make sure that when you've got a Pompe family, you do some family risk screening and make sure you do adequate counseling. And especially the Crum status becomes really important in counseling people about what to do for potential next pregnancies. If you've got a known patient with Pompe disease and you've got the mutations, you could actually go for pre-implantation diagnosis. Now, again, this is an expensive process, but it does allow you to actually select the embryo that is unaffected and implant them. But it is a form of IVF, similar risks and everything. So it's not straightforward, but it is a way. And some of the families I've worked with had 4 or 5 children with Pompe disease, sadly. So for them, it becomes a really important measure. The other thing is I've already talked about, you can do intrauterine testing. And of course, it may be the family's decision to go for a termination. And again, that is a very personal decision. But much, much more exciting for us at the moment is intrauterine enzyme replacement therapy. And I want to tell you just a little bit about this, and I've got the reference for you at the bottom. So the group in Duke with Priya Kristani has started this. So they diagnosed a known family with Gram-negative disease. So this is the really severely onset patient, intrauterine, and they started doing enzyme replacement therapy via the umbilical vein from 24 weeks. They gave 6 infusions up till 34 weeks in this Gram-negative baby. And what happened? Baby was born entirely normal, no cardiomegaly, nothing. They started immune modulation on day 1 after the patient was born, and they continued enzyme replacement therapy. And at the moment, this child is 13 months old and is entirely normal. So cardiac, developmentally, muscular disease, everything at 13 months is entirely normal. So it is a watch this space, but it is really encouraging to see that very early enzyme replacement therapy, even in uterine, may offer some hope for high-risk families. But I mean, this doesn't come without cost, it doesn't come without expertise, and it opens up a lot of other issues. Then there are multiple other therapies in development. I won't spend too much time, but just that you know, so there is a gene therapy study ongoing, AAV. There is some attempts at gene editing ago, and also what we call ASO, antisense oligonucleotides. And then there is multiple other repurposing therapies ongoing to try and see if they can change these patients. But of all these in development, I think the AAV is most probably the most advanced. But then the other thing which we should never forget is that there is also something like very good supportive care. And sometimes that is the right thing for the patient to have. You know, you can control cardiac function. You've got some drugs to relieve cardiac dysfunction, keep children safe. And it may be come to a point where actually palliative care is the best option for that specific patient. And we mustn't forget that. As doctors, we must remember that sometimes treatment does more harm than good. And we really need to be able to have those tough conversations and be really honest with our patients. And if we don't know, ask someone else who does know and help them to get the best advice possible. But it also gives us a wonderful way to think there is more hope for the future going forward. So that gets me away from the Pompe, and hopefully that's given you just a little bit of an insight about Pompe, because this is quite a large topic. What I'm going to do next is I want to take you through to the other. When we talk about GSD, glycogen storage disease, you may not know, but Pompe was previously called glycogen storage disease type 2 because it has an accumulation of glycogen. The difference was only later that people realized the enzyme is actually in the lysosome, which is why it got reclassified as a lysosomal storage disorder rather than being another disorder which is outside glycogen storage diseases. Now, above all of my topics, I will have given you a little bit of a hint. This is not comprehensive. go back to Chris's information or ring the lab and speak to them. But in general, when I look at GSD patients, we make the diagnosis with genetics, or with blood enzyme analysis, or biopsies. Sometimes you end up with liver biopsies, the only options, or things like that. But most of the time we now use genetics. Again, there are very good genetic panels, but the caveat again, many of our sub-Saharan patients doesn't have standard genetics, so the panels may miss them. So be aware of that. So, but let's talk about some of the others. So glycogen storage disease type 3 is a debrancher enzyme abnormality. So it's the one which is, if you can see on the image, you look at the bottom and you will see this kind of a T, which is where GSD4 and 3 are. And that's what we say is the brancher enzyme. And you will see it breaks the glycogen up before it goes towards the Pompe enzyme, which is in the lysosome. It's a pathway. And the reason why this is important, you will see that just below that, there is also another one. That's the AMP activated protein kinase, or PRKAG2. Now, because both of these conditions, 4 conditions actually, lie at this bottom end, these are conditions for which there is no approval for the enzyme which is used for Pompe. But patients with these conditions will have some benefit, not as much as Pompe patients, but some benefit, because what you're actually doing here is you're doing substrate reduction. You reduce the load that goes into the enzyme, and that's just an interesting case. But let's talk a little bit about the other 2. So glycogen storage type 3, like I say, is the AGL gene. It gets hypertrophic cardiomyopathy, usually in children with a big liver and hypoglycemia. In adults, mostly a muscle disease, just weakness, respiratory failure, and can be quite hard to treat, but depending on the symptoms, treated by supportive care, high protein diets, and a few other things which are going on. Then you've got the PRKAG2, which I've quickly mentioned. This is usually an adult cardiomyopathy with arrhythmia, but also ultra-rare cases has been described. And as most people will know, there's actually one of those cases in South Africa. So these are just ultra-rare causes in that glycogen pathway. And then the last one is Lambert-Danon's disease, which is much more associated with cardiomyopathy, but it is an excellent condition. So you find that the males are much more severely affected. They present younger, but there is lionization of X. So there are females with Danon. So again, don't assume because it's female, it cannot be. And it's just important to keep that in mind. If we go to the next is the fatty acid oxidation defects. This is the whole lot which you see on the right-hand side. You'll see none of us can pronounce them all, which is why we've got all the abbreviations. It's long chain acyl CoA dehydrogenase for LCHAT. So we kind of keep the abbreviations. It's easier to talk about it. But you could see the whole pathway there. And nearly all of those has got a cardiac feature, and a cardiomyopathy relatively common in the majority of those, which is really important. How do you diagnose these patients? Acylcarnitines or organic acids or genetics are the usual ways they tend to come out. Again, I'm not covering the diagnostics. I'm giving you just when to look out for these specific conditions. So usually they have a cardiomyopathy with muscle or liver involvement. Again, like I say, and these are just all the different names of these different conditions. A hint I can tell you is that in general, there's always an exception. In general, the longer your chain length, the more severe your child is, and the younger they are at presentation. So for that reason, you'll find that LCHAT and trifunctional protein is usually your youngest children the most severely affected. And as they go, the chain length changes, they actually become a little bit less severe. And it's most probably the best way to say that. And then right at the bottom, you will see something glutaric acidemia type 2, which is also called MADD, which is MAD. It's not because that's what's wrong with the patients. It's the abbreviation for multiple acyl CoA dehydrogenase deficiency, so multiple enzymes. And of course, you will know there is a common mutation in Southern Africa, and there are 2 types of this disease. One has got a riboflavin responsive and one is unresponsive. And it's the unresponsive one that primarily gets the cardiac disease. So it's the one which is unresponsive. And some of them even have cardiac abnormalities intrauterine, can be quite severe with cysts in kidneys and many other abnormalities. Next on is don't forget about just primary carnitine deficiency. A lot of people kind of think, oh, carnitine is this special thing that makes you wonderful in sport and things like that. I won't go down that line, but just to remember that the majority of carnitine in the human comes from your diet, about 75%, and only about 25% is synthesized. So, but the synthesis is highly dependent on having all the cofactors, pyridoxal phosphate, N-niacin, vitamin C, iron, everything else. So because of that, you find that patients with primary carnitine deficiency usually hide pretty well as children. And they usually pitch up. Most of the ones I've seen is pitched up during pregnancy, because once you are pregnant, and I do apologize for it, but I usually tell people pregnancy is like you're having a parasite, because the fetus takes the best part of you. It always takes the best. It'll take the majority of the carnitine. It'll take majority of your blood supply and everything. So we tend to see them coming up. So when you've got a patient in pregnancy who suddenly pitches up with a cardiomyopathy, oh, this is a hypertrophic cardiomyopathy. I really do remember about carnitine deficiency, because most of the patients I've seen was diagnosed in pregnancy. And then when we did family screening, we actually identified the rest of the families, and we were able to treat them. And you treat these patients with very high doses of carnitine, and they do exceptionally well. So it's an important condition to remember of. How do you diagnose them? Again, genetics is one way. The other way is you have to have paired samples of plasma and urine. Again, before you collect them, speak to the lab. They will give you the best advice how to do them. So let's get to mitochondrial disease. Now, if you think about mitochondrial disease, the diagnosis is a combination of genetics, muscles, enzyme, urine organic acids, and actually speak to the expert teams. Now, I know there's a fantastic team at Red Cross. There's some collaboration between them and Potchefstroom University and Pretoria University as well. So Sarita Meldo, and I will forget Isel Smits, and now I've got Northwest. I'll try and remember the names, but I'm sure the Northwest team can put them in there. But you've got some wonderful mitochondrial expert people in there. So use them and ask them to help you. What I want to tell you is just a few specific things. One of the conditions which stands out is Barth syndrome. So that is a mutation in the TAS-TAZ gene. But what is different, this is an excellent condition with a cardiomyopathy, can look very similar to a Pompe, usually baby, usually male. The big difference is they've got neutropenia. And that is one of your things. So do remember to look at the white blood cell count. And if you see a neutropenia, just think about Barth syndrome. And there are some specific tests. And there is a specific test for Barth syndrome on a DBS spot again as well. When you start looking at the electron chain defects, usually these are muscle biopsies, get some help. Murph is just one of those groups. There's lots of depletions and deletions, and I won't go into all of them. There's the Q10 or ubiquinone deficiencies, or also the iron sulfur clusters. All of these conditions tend to have some form of cardiac involvement, and mostly muscular, because your muscle carries the biggest load for most of your mitochondrial function in general. Not saying the brain is not important, I'm just saying in general, and brain is another important area. But keep that in mind and get some help from people who know more about those conditions. Organic acidemias. This may not be that well known to people yet. So patients with organic acidemias do get cardiomyopathy. Propionic acidemia is the best described because of its abnormalities we see with a cardiomyopathy. Methylmalonic acidemia, as you know, there are multiple forms of MMA, and I won't go down them. I think at the last count, there was about 15 different forms, depending on how you want to count them. But in general, when we see patients with cardiac involvement in MMA, they usually have had pancreatitis, which is the kind of trigger, the extra load. They get kind of multi-organ failure, and then they've developed their cardiac disease. We've not seen that many primary, but there is occasional cases reported where there was nothing else, there was no pancreatitis, and you suddenly start developing a cardiomyopathy. And again, of course, when you've got an MMA, you consume carnitine all the time, and it can be that the cardiomyopathy is due to secondary carnitine deficiency. So one of the reasons to keep them in carnitine when you watch these patients. Isovaleric acidemia, very rarely. I'm aware of about only one case which has been reported with a cardiomyopathy. So it's not in my list of common ones, which is in there. And of course, organic acidemia says the name, diagnose them by urine organic acids. Acyl carnitine is just as good. Genetics, there's some really wonderful ways to do that. Let's get quickly to structural disease. When you look at structural disease, you're looking at really valve disease. And in general, we see that in all of the MPS disorders and the oligosaccharidosis. I've put a valve on there for you, the cardiac. The aortic valve is the valve we replace the most in our patients with MPS. So although they get mitral valve and some of the other valve abnormalities, we tend to find they don't seem to get into trouble. And the reason for that is unique to the MPS and the oligosaccharidosis. What tends to happen is the valves get calcified and tight first. And then because you've got abnormal calogen, the aorta starts stretching. So you get a dilatation. So your aortic stenosis becomes an aortic incompetence, which drives them into cardiac failure, and you need to replace them. Other things, Fabry disease, we see calcifications, but we don't usually see significant structural abnormalities. Really important to know, there is actually a Gaucher disease, which is a cardiac phenotype. It was originally described in Egypt, but it's now been found in most countries of the world. So there is patients who's got Gaucher disease, but their disease is primary cardiac and nothing else. So keep that in mind. Danon, we've already touched on. Valve disease is part of the picture. Pompe, very rarely do we see actually structural valve disease. We see the other things, but we don't see the structural valve disease. So this is just a short, but just to make sure we cover most of the topics for you. Then if we get to electrophysiological, the first thing I would say is that all of our conditions has got arrhythmia. That's most probably the sad truth of all of it. But let me talk you through a little bit of those just to give perspective on it. Fabry disease is well known because of its bradyarrhythmia, and we have multiple patients which has got either pacemakers or defibrillators implanted. And why do we say that? Well, these patients are high risk, and once we start detecting that they've got episodes of bradycardia or they've got dizzy spells and things like that, our standard procedure is we have an implantable loop recorder, which you see on the left side image. It's a small little cut in the skin. It's basically under the skin, under local anesthesia, implanted, wired in. Cardiologists do it in their office. And the patient read this with a little device and download the data on a regular basis. And it tells you when there is significant abnormalities, if you need to place a pacemaker or a defib. So that's just how we diagnose it. When we look at the other arrhythmias, we find arrhythmias very common in our older MPS patients, particularly MPS 2. We haven't particularly figured out. We think for some reason the GAGs deposit mostly around the physiological bundles in MPS 2, primarily more than in some of the other conditions, but not entirely sure why. Again, they get bradyarrhythmia, so usually patients would need pacemaking rather than anything else. Pompe disease is actually interesting, and it's really important for people working with very young Pompe patients, is that when you need to put in a line, you need to give them a general anesthetic. But these very young Pompe patients act very much like other muscular dystrophies. So which means they're very sensitive to inhalant anesthetic agents, frequently get VT and end up in a lot of trouble. So our anesthetist tends to use infusion protocols, mostly propofol based, to place lines and things in our Pompe young babies because they've seen so many arrhythmia, especially with the inhalation agents. Fatty acid oxidation defects, we tend to see mostly VT in these patients. Again, not that common, but we do see them, and especially in the young patients. Again, mitochondrial disease tend to see more conduction blocks just by the way of the mechanism. And then with the organic acidemias, we've seen basically, particularly in our propionic acidemia patients, from about the ages of 12 to 14, we start seeing long QT developing in some of them. And those who develop long QT develop acute episodes of VT. We've lost a few patients until we actively start looking for them. And we now proactively prevent them and put loop recorders in the moment it starts looking. And we do regular ECG recordings on them to make sure we catch them early. Next is basically my last slide, because I want to leave some time for discussion and questions and things as well. And that is really just to say that when you see cardiac disease, think rare, but also think IEM, because I hope I've convinced you that actually cardiac disease is incredibly complex, but also common in many of our disorders. And either they are the presenting feature or they are the complications of the future, and you need to keep your eye on that. So happy to try and take some answers if there are any questions at the moment.
Thank you very much, Chris. Colleagues, please post your questions in the question and answer section. But you're also very, very welcome to join the discussion. Just raise your hand and we will unmute you, and you can ask your question or make comments. We welcome that. So there's no questions at the moment. So while we're waiting for people to post their questions, Chris, we predict CRIM status from the genetics.
Yeah.
And most of the time it works quite well. But you do have cases where you can't actually make the prediction from genetics, and then we have to send the sample to the United States. It can take quite a long time. And I've seen publications now that advocate for doing the immune modulation if you don't know the CRIM status. What do you think of that?
Yeah, I think you can be pragmatic about it. So I think when you see a Pompe patient under 6 months of age, especially under 3 months of age, you can be fairly sure it's going to be a CRIM negative. And that's what people have done, because it takes so long to get the results back and you lose that window of opportunity. So the idea is that basically you start your immune modulation in all your young patients, and that's what a lot of people are starting to do at the moment. Just immune modulate all of them, and then once your CRIM status comes back, you stop it. But you have to remember, immune modulation is not without risks. And I think it's just that people know that, you know, your risk of infection is particularly high with the immune modulation. And because you've got very young babies, which are generally quite sick, if they get a reaction to the immune modulation, they get very sick, and you need to really be careful. So it most probably needs to be kind of very well managed and controlled. That's the only thing. But I absolutely agree with you. If you don't have the genes and you've got a very young baby, my advice would be I would immune modulate, especially if they're young, because the fact that they present so early by default tells me that they're going to be CRIM negative. And I think people have done some really good analysis of that. And I think there is a cutoff. I've not seen it published yet, but I think there was a suggestion that anything less than 4.5 months is most likely, except newborn screening. I exclude newborn screening, but any clinically presenting Pompe less than 4.5 months, the likelihood of CRIM negative is much higher than CRIM positive.
Okay, thank you. Bertram Henderson is saying, thanks for another insightful talk. Is POTS associated with any IEMs? Okay, so it is, I suspect he means postural hypotension, orthostatic hypotension. I hope that's what the POTS is. It's the abbreviations. And yes, it is, but it's poorly reported. So that is another one of our, and we see POTS in our MPS patients, and we think it's most probably a loss of their normal counter-regulatory mechanisms. So we do see it in some of our MPS patients. And of course, it's likely to be prominent in the mitochondrial diseases, but I don't see a lot of people actually doing anything about it. But yes, it's definitely, and I'm trying to think if there's any group that we've missed. The group that we've got very little information on is some of the things which is all common in your part of the world, of course, is the CDGs, and they are multi-system disorders. I would be surprised if they don't have cardiac disease. Do they have POTS? I don't know. Just also for the audience, these CPD events are recorded. It is available on our YouTube channel. So just that you know, afterwards you can review it again. Anonymous attendee is asking, can the CRIM status vary in members of the same family?
The usual answer is absolutely no, because you need to. The only thing which can catch you out, and I've been caught out not with Pompe, with another condition, is that sometimes you've got a family which has got 2 mutations in cis for the same disease. So if you've done your homework and you know the mutations are right, and they are basically you've done the whole gene, you've just not looked until you found the first mutation, and there isn't another mutation, then yes, the CRIM will be the same in all of it. But don't get caught out by when there are 2 mutations of the same disease in one of the parents. And we find that in highly consanguineous families frequently, so just be careful on that one. But as a general rule, yes, the CRIM status would be the same. So if you've had one CRIM negative, it's most likely that you're going to have all your children CRIM negative as well.
Yeah, I must say, look, we usually get the genetics quite quickly. The referral lab's aware of the fact that we need the result quickly to start the enzyme replacement therapy and to deduct the CRIM status. But it's those cases where you can't predict from the genetic results what the CRIM status is going to be, that, I think, like you mentioned, we need to consider other factors in making the decision, as opposed to just waiting for the result.
Yeah, and make sure you don't miss the baths. That's why I bought the baths in. Just make sure you've got a definite Pompe. And of course, if you've got the mutations, you don't have the risk.
Okay. Ashmam Abdallah, fantastic. Thank you very much, Prof. Chris. I had one patient, 3 months, with a huge heart and cardiomegaly. Family lost many babies unexplained. The weird thing that he had remarkable tongue fasciculations. Genetics came back confirming Pompe. Neurological features are classical in such an age.
Yeah, we see them. They've got the hypertonia. The fasciculations has been reported in some of the patients already, and they're also reported not only in the tongue, they're also reported in other parts, especially in the lower limbs. They've been reported in as well. There's a lot. When you look at the classical Pompe disease, you have to remember this is a neurological disease, a muscular disease. So they've got problems with swallowing, they've got cardiac disease, they've got poor tone, they've got the poor respiratory drive. So they've got lots of things. And it really is a much more neurological disease. And we are just starting to see the first classical patients getting into adulthood now on enzyme treatment. And what that looks like, we don't know yet. But some people are reporting more and more issues with speech and also swallowing as they start getting older. So it seems that not everything is controlled, even by the enzyme replacement therapy as they get older, or if this is a pure dose effect, we need to dose them much higher or more frequently.
Okay, follow-up question from Ashmam is saying, our colleagues used to give L-carnitine as a routine for cardiomyopathy patients. Do you see this, or how do you see this practice?
I've seen this practice sadly go wrong, because if you've got a long chain fatty acid oxidation defect, you can push them into arrhythmia. So I would just make sure I've got something to make sure it's not a fatty acid oxidation defect. I don't routinely just start things. And similarly, I'm against all of the standard vitamin cocktails and things for mitochondrial disease and things. I think you get yourself in a mess, and you mess up sometimes your investigations and things. So I think you need to be thinking clearly. Once you've got all your samples collected, yes, of course you can. And things like organic acids and acyl carnitines can be turned around very quickly. So, but I know, Asma, in your part of the world, nothing is quickly. And the question is, I think you need to know your epidemiology. I think if you really think which patients will benefit from carnitine, your primary carnitine deficiency are older patients. The ones that will really benefit are your organic acidemias. Early onset organic acidemia will have other features. They will usually have an acidosis, they'll have an anion gap, they might have a mild elevation of ammonia. There'll be other hints before. I wouldn't just give carnitine if there is just basically, because I know some people are now starting to give Q10 standard as well. And again, I think we just need to be really careful of just randomly giving things until we've got some idea of what is the cause.
I know some countries have now discontinued primary carnitine deficiency from newborn screening programs. Why is that?
It's because you can't pick them up. So on the newborn screening, you don't routinely pick them up, and they don't need treatment until they're much older. So that's why some of the people have actually started taking them off, because they say it just creates more headaches for people trying to follow them up, which is why I said that. And I don't know what your practice may be worthwhile saying about that. We are spoiled. We do everything with genetics now. But I remember previously, most of the times we just do a early morning, both a urine and a plasma carnitine, and look at both of them, and then start looking and untangling it.
Okay, yeah, that is our practice as well. Chris, there are no other questions. I'm going to just ask one last question. You know, in in the laboratory, we always try to dissect symptoms and connect diseases to those symptoms. So, you know, at one stage we had a lot of discussions about hypertrophic versus dilated cardiomyopathy, and if that has any relevance for selecting appropriate tests. Now, I know that this is important to the clinician, but I also think, you know, sometimes, particularly if it's early onset, then the clinician may, well, in cases of Pompe, you're probably not you're gonna be sure, but in some cases, they're not always sure whether it's hypertrophic or dilated. And do you think there's really relevance in knowing the type of cardiomyopathy from a laboratory testing perspective?
No, not for me as a clinician, no. I think there's a need for that for a cardiologist who's going to manage the patient. But for me as a clinician, I need a diagnosis, and I don't know. Was the patient hypertrophic and then became dilated? You know, I don't know where in the disease I am. And if that's going to stop me making a crucial diagnosis, it's not the right way to tackle it. So that's why even today you've heard, I've spoken about just cardiomyopathy. I didn't even go into trying to classify it and things. There are very smart cardiologists, and I leave that to them. I just say there's a cardiomyopathy, I want to know what's wrong with them. And they would come in with their supportive care, because depending if it's hypertrophic or dilated, they will have different strategies of how they would manage them.
Thank you, Chris. Okay, there are no more questions in the chat. I just want to conclude by thanking Sanofi again for sponsoring our CPD presentations. Really enabled us to elevate the standard and quality of the presentations. Again, just to assure you that they have no say in the selection of topics and also in the content of the topics. Thank you very much for attending this evening, and I look forward to seeing you next time. Have a good evening and goodbye.
Thank you, everyone. Goodbye.